Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC, where we're going to review the highlights of the October 2nd issue of the journal. The first paper I'd like to tell you about deals with the issue of diabetes and statin therapy. And as everybody's aware, there's been a lot of attention paid to the fact that the administration of statins can be associated with an increase in diabetes. And so to look at just how common this is and how it influences overall survival, a study was done in Taiwan from the National Health Research Database. And these particular investigators took this database, retrospectively went back and identified a group of patients who were taking statin therapy over a period of years and matched them in a 4-to-1 ratio with similar individuals who were not taking statins. They then followed these individuals along, looking specifically at the prevalence of diabetes, at the rate of myocardial infarction and stroke, and also at the rate of in-hospital death, which was available to them through the database. So what they found was, indeed, there was an increase in the rate of diabetes in the patients taking statins, but this was relatively small. In fact, it was the difference between 2.0 and 2.4%. So only a very small percentage of patients in either group developed diabetes, and it was trivially greater in the patients who received statins. On the other hand, the incidence of infarction, stroke, and hospitalized death was less in the patients who had received the statins. And so these individual investigators concluded that the increase in diabetes was more than offset by the reduction in overall cardiovascular events in the patients who did receive the statins. Now, of interest, those patients on statins who developed diabetes seem to have a higher incidence of events than the patients on statins who didn't develop diabetes. So that my take on this particular issue has been that there is indeed an increase in diabetes in patients on statins. The increase is relatively small. We ought to be able to detect it readily by laboratory testing, which I've started to do most carefully in all my patients. And in those patients, one can decide if the high risk or secondary prevention of statins in those patients offsets the low risk of diabetes. Another issue that's really come to the forefront recently is the patient with low gradient but severe aortic stenosis and preserved ejection fraction. And this is a group of patients that traditionally in the past have been considered not to have severe AS, but recently the group from Quebec, Canada, has shown persuasively that in this particular condition, these patients in fact do have rather advanced degrees of aortic stenosis. And so the paper in JACC that we have this month deals with whether or not the prognosis of these patients is worse than patients with severe AS by conventional criteria or moderate AS. And so this group of patients typically has an aortic valve area of less than 1 square centimeter, but they have a mean gradient of less than 40 millimeters of mercury, and this is due to a stroke volume index of less than 35 cc's per meter square body surface area. And that's distinguished, of course, from the severe AS with a small valve area and a high gradient, and from moderate AS where neither the valve area nor the gradient is very critical. And they compared about 105 patients with this low gradient preserved EF aortic stenosis with a comparable group of patients with severe AS or moderate AS, and they observed that the survival was reduced. Interestingly enough, a lesser survival. Now, why should survival be more reduced in this group of patients? Well, it's speculated that they were older, they had worse myocardial function, perhaps more comorbidities, and it was observed that they were less frequently subjected to aortic valve replacement. So what's the lesson here? Well, the lesson is that this newly described cohort of aortic stenosis patients really do have serious disease, that we should be very aggressive in managing them, even if the gradient is low, presumably due to either impaired myocardial performance or high valvulo-arterial impedance. Now, the $64 question is, should we move on these patients before symptoms? And this particular study can't address that at all. Nevertheless, a new cohort of aortic stenosis patients with a reduced survival, and one we need to treat very seriously. One of the really interesting studies in the October 2nd issue of JACC is called the WHICH trial, W-H-I-C-H, which deals with the question of which form of therapy is most effective in patients with heart failure who have been hospitalized. Are they better getting home-based intervention or clinic-based intervention? And so a group of investigators in Australia undertook to study this in about 280 patients who had been hospitalized for heart failure. And they were randomized to either a home-based intervention, which was carried out by a nurse with a home visit somewhere between 7 and 14 days post-discharge, or a clinic-based visit, again led by a nurse in the same time period. And when the nurse was at the home-based visit, they took into account not only the heart failure in the patient, but also the cultural surroundings, the access to diet, the access to pharmacy, family support, things which were a little bit more apparent at home than they could be in the clinic. Now, the clinic nurse attempted to evaluate exactly the same parameters. They then followed these patients along with an endpoint of unplanned hospitalization primarily. And as an additional endpoint, they also evaluated death. What they observed, interestingly enough, was there was no difference in the primary endpoints, that is unplanned hospitalization or death, between the home-based intervention and the clinic-based intervention. So even though one might hypothesize that having the opportunity to evaluate a patient in their own home setting might enable you to treat them more effectively, that wasn't the case as regards the primary endpoints. However, more patients seen in the clinic underwent overall hospitalization, scheduled and non-scheduled, and longer hospitalization, so the cost of the home-based intervention was less. So interesting data. Another study that fails to support what might seem to be the logical conclusion that a more intense evaluation at the home would lead to better results than in the clinic, but nevertheless an important cost savings, especially relevant in terms of rehospitalization in heart failure patients. So, lots of controversial topics in this month's Interest of JACC. Diabetes and statins, the value of home care for congestive heart failure, and low gradient normal EF aortic stenosis. A lot of interesting information on these important questions. For Inside JACC, I'm Tony DeMaria.